Welcome, everyone, to the Investing in Referral Networks to Advance Racial Health Equity webinar series, part 2. Why increased investments in networks are integral to advancing health equity and delivering community impact. Before we begin our conversation today, there are a few housekeeping items that I'd like to review. Today's event will be recorded and sent to everyone who registered and uploaded to the Health Leads website and YouTube. During today's event, we'll have time to answer as many questions as possible.
Okay.
So please submit Please submit all of your questions using the Zoom Q&A button found at the bottom of your screen. You can also use the Zoom chat feature to share comments, reactions, and links with your fellow attendees and panelists. This webinar also has closed captioning available. To enable closed captioning, please click on the closed captioning icon at the bottom of the Zoom screen. Last but not least, at the end of the webinar, we'll be launching a poll and evaluation survey. So please take time to quickly share your feedback on today's webinar and suggestions for future offerings. Thank you. As we begin our time together, a way that Health Leads really comes into the space and allows all of us to bring our authentic self as we use practice agreements. And so those of you who were with us 2 weeks ago for webinar series 1 will be familiar with our Health Leads practice agreements. And I'll read the bold lines. Address racially biased systems and norms. Be brave, be inclusive. Be open to anti-racist dialogue. Be present, be accountable. Take space and make space. We find these agreements are helpful when we are in spaces with one another to really be able to share and be authentic and be respectful. Next slide. Along with our practice agreements, we have racial equity guides. And that allows us to really be mindful of the racism that exists in the world that we are navigating. And so our solution is to really call in and call out those systems of inequity. And so with that, we have racial equity guiding principles to help us do that work. And so we believe in with us, not for us. Fix systems, not people. Commit to collecting both quantitative and qualitative data about race, ethnicity, gender, etc., and use it to recognize and support the greatest needs. And self-awareness and self-correcting behavior, allowing us to take a moment to think about what triggers us and how can we, how does that impact our decisions and the choices. So take a moment to think about that. Next slide. And as we get started in our process, we wanted to have a centering and a center on a question. If your budget increased by 25% tomorrow, what would you prioritize in your CRN? Feel free to put your answers in the chat. Thank you. And hopefully we'll have a chance to pull up on those at the end of our hour today. Next slide. So welcome everyone to why increased investments in networks are integral to advancing health equity and delivering community impact. And with us, our panel discussion will be Saskia Garcia, our interim director of Sonoma Connect, Sonoma Unidos. Stacy Kellogg, director of social services for People. Tim Sullivan, director, Washington 211. And Hannah DeVivier, our program manager here at Health Leads. And my name is Artrice Morrison, and I'm your moderator today. Welcome and enjoy the conversation as we continue. Next slide. Next slide. So in terms of Health Leads and who we are a nonprofit organization working locally and nationally to remove deep-rooted systemic barriers to health and center power and resources within communities and build a world where racial health equity is the standard. Our vision is health, well-being, and dignity for every person in every community. And so we appreciate you being part of our conversation today. Next slide. Once again, welcome to the second part of our webinar series, where we delve deeper into the critical role of community referral networks in bridging the gap between individuals and essential resources. Building on the themes of our community voice, trust, and accessibility explored in our first webinar, we now turn our focus to the challenges of funding and resourcing CRNs. In this session, we'll tackle key issues such as staffing, finances, impact measurement that are vital to the success of CRNs. Our distinguished panel of community-based organization leaders will share their individual insights on effectively managing CRN resources and partnerships. Additionally, we will examine investment strategies aimed to supporting the financial and programmatic sustainability of CRNs, taken into account the unique ecosystems of our diverse communities. Through chat, your questions and comments join us in this conversation as we navigate the complex landscape of CRN funding and resourcing needed to bolster the impact of these vital networks in connecting individuals with support they need. Next slide. So our project, the research to pursue and advance racial health equity, RePARE. Through this project, we began to understand how the sector can design, implement, and sustainably support community-anchored referral networks in order to advance community health and racial health equity. Next slide. But as important as to what we were trying to understand and what we do, it's how we do it. And our approach was rooted in liberatory and equitable design practices. We grounded our work in the CIE Data Equity Framework, We All Count Data Equity Framework, the National Equity Project's liberatory design practices. It was important for us to interrupt inequity as we gathered information with community as opposed to from community. Next slide. And again, we really want to thank our participating network organizations, those you will see, talk to today on the panel. Our community advisory group members who you met 2 weeks ago in our last webinar, and our investor advocates who made this project possible, Common Spirit, Blue Shield of California, and California Healthcare Foundation. Thank you so much for your partnership. Next slide. Now we'd like to welcome Health Leads team member Hannah Duvivier to present the importance of community partnership and the information that we gathered through the financial work stream. Thank you.
Thank you, Artrice. Hi, everyone. My name is Hannah Duvivier, and I'm a program manager here in California with Health Leads. I'm really excited to share with you today our research findings. Next slide, please. So I want to give a little bit of background around how we landed on our research questions. Back in November of 2022, the participating networks did a brainstorming session about what they were most interested in researching around the themes of costs and funding of networks. Then the Health Leads RePARE team grouped these ideas, and we found 12 unique themes that we brought to the RePARE investor advocates. So again, that's Blue Shield of California, Common Spirit Health, and California Healthcare Foundation, who then voted on which research questions they felt were most important to look into. So our data comes from the 7 participating networks across the country. Across these networks, we received 19 staff surveys around what it takes to run a network. We received and analyzed the total budgets of the 7 networks, and we asked network leadership to tell us what data they collect to measure their success as a network, and we received 70 of those measures. Next slide, please. So today I'm excited to talk to you about our main findings around staffing, funding, and impact of community referral networks. Next slide, please. Thank you. So when we looked at how staff spend their time, we found that direct service staff represent an unexpected key segment of network staffing models. So as we analyzed the budgets in the surveys, we discovered that 4 of the 7 networks have non-insignificant direct service staff as part of their staffing model. And this includes roles like community resource navigators and referral coordinators. There's a high degree of variability in these monetized investments of direct service, ranging from 15% of a budget to 77.5% of a budget, which are substantial percentages. Resource navigators are also not an insignificant percentage where they're deployed, so we see that direct service trend persists there as well. So really the point here overall is that more budget and more staff are dedicated to direct services than expected, yet we don't have the people or the funding to support direct service in significant ways. And this also highlights the diverse responsibilities of networks in supporting their communities across the country. Next slide, please. So when looking at how networks are staffed, we saw that the risk of burnout is heightened as networks seek to deliver impact with their limited resources. So overall, the network operating budgets tend to be skewed towards leadership roles, and there are a few roles dedicated to direct service duties like outreach or education, which were reported to be significant staff job duties. This imbalance increases the risk of employee burnout as limited staff are taking on an oversized burden of responsibility. The budgets showed us that while the size of each network staff roster varied significantly, the most prevalent role across all of the rosters was manager, which showed up in 6 of the 7 budgets, and executive leadership and directors showing up in 4 of the 7 budgets. So our analysis really showed that director level staff and above tend to have more unsustainable workloads, and they also report that their tasks take longer than they've anticipated or that they've expected. So network staff budgets and rosters really need to reflect the importance that networks are placing on direct service in order to avoid professional burnout. So overall, in terms of staffing, networks should really revisit their staff rosters and responsibilities to be able to more sustainably allocate available resources to managing and mitigating staff burnout, while also working towards creating more manageable workloads for staff. And then investors should be prioritizing funding that focuses on direct service. Next slide, please. So when we looked at how networks are funded, we found that the current network revenue strategy is incredibly risky and unsustainable, as they're often heavily concentrated, they can be subject to political headwinds, and depend on unreliable supplemental sources. So networks are really calling on more government investment to reduce reliance on sources that may have shifting priorities. So across 26 funding sources that were analyzed in these 7 budgets, we saw almost $8.6 million in committed funding, with $11.4 million in year-to-date costs, showing that this current funding structure is unsustainable and high risk with an almost $3 million deficit. To meet this deficit, with 18% of the revenue tied to backbone support, a lot of networks require drawing down from funds that are not actually designated for the network themselves. And you can see here on this graph that health systems are one of the smallest investor type at 1% of revenue. And you might be thinking, so what? It's only 1% of revenue. Well, health systems make such a small percent of revenue, but these relationships require high levels of engagement over long periods of time. And it results in a modest amount of funding that can be subject to shifting health system priorities. Sole source funding models also pose a great risk to CRNs, and 4 of our 7 networks report that they are fully resourced and supported by a single funding source, and this ranged from a local government grant to backbone support. And it's also important to note that Even with multi-source funders, while you may have more depth of funding, it ultimately leads to more metrics that need to be reported on. So really, what I really want you to take away here is that networks should seek to diversify their funding wherever possible, and consider multiple funding sources so as not to rely on sources that may shift priorities away from community. And investors should engage more deeply with the networks that they fund to help ensure adequate financial support for delivering community impact. Next slide, please. When we looked at how networks communicate their impact, what we found was consistent with the direct service findings. Networks and funders have differing interests around what gets measured and reported on. So this often means that networks are tracking two sets of measures, those that measure direct services delivered and those that are required by funders. So we received a total of 70 of these success measures from across the 7 PNOs, with most of the measures being funder mandated. 4 of our 7 networks report measures that are not funder mandated, which indicates that many networks have measures that are focused on delivering services rather than on measures that may be required due to contractual obligations with funders. Networks focus on tracking these direct service measures because they know how crucial direct service is to running a successful and efficient network. Yet this measuring strategy can also contribute to burnout with how limited time is to complete network tasks and how many different measures need to be reported on. There's simply not enough people to complete the work. And as noted in the previous findings, funding is not necessarily going towards supporting direct service providers and services. And we see that trend here too, with networks believing that quality direct service indicators are the most important measures to be reporting on to demonstrate the success of a network, but they aren't prioritized because funders are requiring other measures of success. Now, regardless of whether the measures are funder mandated or not, networks are finding it important to track these additional direct service measures, which really speaks to what is valued most by funders and by the networks themselves. So the point here is that funders and networks really need to align on their measurement requirements to include more of those success measures of direct service that the networks find important to report on. And this alignment would really allow networks to more efficiently use their staffing resources by not recording and reporting on 2 separate sets of measures. More focus on the direct service success measures would also help the CRNs highlight and demonstrate their true impact in the community. Next slide. And I'll pass it back over to Artrice.
Hannah, thank you so much for that enlightening information. And to recap what you're saying as it relates to 2 weeks ago when we talked about the community impact of the need of relationship building and trust and quality of service and addressing people and meet them where they are regarding their diverse demographic that come to the conversation and come to for services. We need to really kind of balance that out and think about investors in considering prioritizing funding and focusing on the direct services that helps to support staff and reduce the amount of burnout that folks are experiencing so that that quality service can really be there. And then deeply engage the networks that they fund to better understand the strength and sustainability of their models, so they're not left to the whims and the changes of the priorities that are happening in the environment and still can be able to serve their clients. And also broaden their understanding of what quality measures and impact measures should be so that they really do have a connection with the clients that we wish to lift up and serve in these models. So in the service. So really appreciate this information. And so now is a wonderful chance to bring in the folks who are in the front lines of this work. And so we welcome Stacy and Saskia and Tim into the conversation. Wonderful. Okay, perfect. We're all here. Thank you all so very much for joining us. And thank you all for being such great partners in this 18-month project that we've embarked on. And so please, Stacy, introduce yourself and your story. Like, how did you come to this work?
Yeah, so you can hear me. Great. Thank you so much to the health leads team. You guys have been incredible in guiding this work, and it's a topic that we feel so passionately about. So we're so happy to be here to discuss that with you today. So in my role, I come to you from Yakima, Washington. If you're a beer lover, we grow your beer here, 70% of the hops. And in my role here, I oversee the Greater Columbia 211 call center, and we cover 16 primarily rural and agriculturally based counties in Eastern Washington. We are part of the Greater Washington State 211 network. And for as long as I can remember, I have just wanted to help people. When I was young, I didn't know what that would look like, and I certainly didn't know that that would mean that I would someday be the director of a call center. That was not on my radar. But I wanted to help, and people and their shared experiences are fascinating to me. I've been in this field for over 30 years and with 211 for nearly 13. And my why and my fundamental belief is that when people have the information and options they need to make informed decisions about their lives and are connected to the right resources or people, they become empowered to not only survive, but to thrive. My why can also be summed up with my probably all-time favorite quote, which is just, we are all just here walking each other home. And I'm so glad to be on this journey with you all today. Thank you so much.
It's wonderful. Thank you, Stacy. Really appreciate that. Tim, will you introduce yourself and tell us your why?
Sure. And again, thank you for the work you've done. I think this is valuable research. And I think it's a good advocacy tool as well for the work that community networks do. And so I really appreciate the work that you've done. So I've been in social services for over 32 years. And actually, when I came out of college, it wasn't my area of focus. I just kind of fell into it right away. And so I got to work in socially disadvantaged communities when I grew up. My first actually job out of college was working in very economically challenged communities where there was a lot of gang violence, youth violence, and drug use. And so I immersed myself in those communities doing youth programs. And so I really got a passion for helping people, but also understanding the economic impacts and racial disparities that impact communities, and really grew appreciation for that. And so that kind of just really guided my whole life. I also had a great mentor as well in my first job. Then I moved on to United Way of in Yakima County. It's actually United Way Central Washington now, but I was a community impact director, and there I really got to touch on really kind of the idea around networks, because we did a lot of work around networking with our organizations that we funded to do, some collaborative work. And there was always the one key piece to all services is information referral. So whether it was our United Way doing a little bit of information referral, or it was the organizations we fund, they're all doing information referral, trying to connect folks that come in to see them to other resources. So it was this kind of this blanket need in the community. And so it was something I always used or really attached to. And so got an opportunity to actually got really engaged in homeless issues and became the director for our county's housing homes programs, and really got an education on housing disparities and what causes that and who it impacts. And it really just kind of continued to increase my passion. But the one thing again that was weak and I really wanted to see happen is more connecting of people to resources, because we still have people calling the county number or United Way or whatever, trying to find services. And so when 211 came around, I was engaged in some of the early development because I was with United Way, and really thought this is the thing that United Ways need to be doing. And so I really got passionate by that. And then eventually an opportunity came up for me to actually apply manage the state program. And so I've been doing that since 2016. And we've done a lot of things around innovation, especially around trying to fund the service, because it is always a struggle. And so I'm happy to be here and talk a little bit about, my experience around that. But again, I'm impassioned by, trying to change systems for the better. I'm kind of a systems thinker, kind of a visionary person, and try to look at what are the underlying issues and how can we address those collaboratively.
That's great, Tim. Really appreciate that. And Saskia, please, you can share your why and who you are.
Thanks, Artrace. My name is Saskia Garcia, she, her pronouns, and I'm joining from Santa Rosa, California, from the unceded territories of the Pomo and the Coast Miwok people. And I came to this work to contribute to healing and anti-racism in my community and our society. And even as a child, I recognized how people's life experience, my own included, can be influenced by our race, our financial situation, and childhood adversity, and which gave me a lot of empathy and curiosity about how we survive, how we heal, and how we enjoy life despite trauma and challenges. And I seek to solve deep social issues, including adverse childhood experiences, from racism and abuse to poverty and neglect. And I commit to hope and dedication and healing in how I approach this work. I currently serve as the interim director for Sonoma Connect, Sonoma Unidos. We are a coalition of nonprofits and multi-sector partners that are leading development of a community information exchange model network in Sonoma County. And I especially love community-led solutions. I am passionate about how we can strategically build community health through centering the voices, especially voices of people most impacted by systemic inequities.
Wonderful. Thank you all for your deep well of knowledge and experience. And I am excited about this conversation today. And as we speak a little bit, the three of you, and then welcome the audience into the conversation a little bit later. Saskia, we heard a lot about direct service from Hannah and the importance of it. Can you talk a little bit about your experience with direct service and the day-to-day activities and with Sonoma Connect and Sonoma Unidos?
Yeah, so Sonoma Connect, Sonoma Unidos, as I mentioned, we are a coalition. We have a small backbone team of 4 staff, and we don't currently provide direct services, but they are 100% integral and interrelated to our work. So together with partners, as I mentioned, we are implementing a community information exchange model network to support collective impact and positive physical and mental health outcomes as cross-sector organizations. And one piece of our work is implementing a powerful new technology. We refer to it locally as the Resource Connection Network. And it's intended to support closed loop referrals and cross-sector information sharing. We are spearheading implementation of this technology together with our 211, which is administered locally by United Way of the Wine Country, as well as our core partner, Aliados Health, who is a consortium of health centers in our region, as well as our fiscal sponsor, Community Action Partnership of Sonoma County. And we partner with a growing number of nonprofits that provide community services, including housing, financial assistance, mental health support, access to healthy food, legal assistance, and much more. And as we work on community-led infrastructure to support cross-sector information exchange, we recognize that technology cannot and should not replace the critical workforce that will leverage the Resource Connection Network. So that includes our community health workers, our resource navigators, our school behavioral health staff and school nurses, housing and benefit navigators. We have a lot of direct service staff who provide critical resource navigation and help people navigate our complex systems, and these roles will continue to be incredibly needed and important. And we certainly recognize that we're in a very dynamic environment in terms of our broader systems, as our systems are seeking to shift and increase physical and mental health equity. Right now, we know that there's a lot of recognition for the role that social services play in physical and mental health equity, as demonstrated by initiatives in California, like CalAIM, which is innovations to Medi-Cal, the California, or the Children, Youth, and Behavioral Health Initiative, and also AB 133, which is the Assembly bill, which requires exchange of social determinants of health and other health data. And I know that there's like several initiatives coming up in New York pertaining to this right now as well. So I also just wanted to have, you know, a little side tangent on direct services. We know are not always sustainable, and many of our funding streams fund only a portion of the actual costs that it takes to implement these direct services. Recently, the California Healthcare Foundation completed a survey related to the success and efficacy of CalAIM implementation, and 56% of providers reported that it's challenging because payment rates are not covering the full cost of services.
Thank you so much for that. And you answered so many questions that were already popping up about what is direct service and what does that mean, and that I really appreciate your answer. And as it relates to the question that we had in the chat in the very beginning of, if you had 25% more people had added, they'd pay their direct service staff. They would pay their direct service staff more. So there's still such a relevance to that. So thank you for that. And Stacy and Tim, I don't know if you have any thoughts about this direct service conversation. I just wanted to give you a moment. Okay, so Stacy, I do have a question for you as it relates to staffing. And so your experience with understaffing and the difficulties of hiring folks to do this work. And so where else do you need capacity?
Yeah, so the question of, is the network adequately supported for our capabilities? And the simple answer to that is no. And I think that that's going to be obviously a common theme of this discussion, and can definitely relate to many of the things that Saskia mentioned. In our community resource network experience as Washington 211, we have not had adequate funding support to fully fund our work. My colleague Tim Sullivan is going to be speaking to how the network is funded. So I will focus on more of the lack of funding and how that impacts our staffing and ability to educate and outreach to more people and communities about our services. In my 16 county region, I currently have a couple paid outreach staff that cover 4 of the counties. So that means that 12 of the counties do not have an individual actively out there connecting to the resources and the providers and the community. This not only makes it difficult to ensure that there's access and equity across all of the counties equally, but it also puts us at a disadvantage in being able to update the resource database because we don't have that knowledge. When we don't have individuals, boots on the ground in those communities, at the local meetings, at the local events, we may not be alerted to the changes in services, service closures, or new services that may be popping up that would be wonderful to present to our callers. Our community resource specialists who answer those calls for 211 are amazingly knowledgeable, compassionate multitaskers, and often come to us with a really rich experience, a rich lived experience that makes them connect to this work and makes them empathetic and relatable to our callers. Our specialists their training is very extensive, and we are Inform USA, formerly AIR's accredited call center. We are in our 3rd accreditation, so we take those standards really seriously and providing that quality service. And that is meeting the 27 standards put out by Inform USA, which is kind of that gold standard membership organization spotlighting information referral. We also encourage our specialists to become Inform USA certified. This also gives them additional training and can help ensure that they're doing meeting those standards for each of those calls. Takes on average, I would say, having done this work for the past 11 years, it takes a good year for a specialist to really become trained and competent to take the variety of calls that are coming at them. The amount of information that they have to keep track of, and yes, they have a wonderful database, but oftentimes it is just their experience taking those calls that really starts to create that proficiency. Our database management is also a certified position of a data curator, ours is currently certified as well. These are competent, skilled professionals that work in a highly stressful field. And we talk about 211 really being a crisis response because almost everyone that calls us is in need of something that's very important. It's often related to a basic need, such as housing, shelter, transportation, food. So they are in a vulnerable state of crisis. And burnout for our staff can come from, these very difficult calls, also from the low wages that are paid because we don't have the proper funding to support enough of our specialists. And there's a feeling of helplessness that comes across a lot of our specialists when they're continuing to look at that call queue that seems never ending, and it just keeps coming and doesn't stop, call after call. Never feeling like they're going to be able to clear that queue, and the emotional toll that takes on them is intense. They have limited time away from responding to the calls because we are short-staffed. And one of the biggest burnouts we find is from staff not having a resource to give to people, and quite simply, they are helpers. Our specialists are helpers that want to help. That's why they're in this field. So when they can't do that, when there isn't that resource, that is another factor of burnout. 211 value was proven throughout the COVID pandemic. Washington 211 was asked to operate the Washington State Department of Health COVID information line, which we did from March 13th of 2020 through June 30th of 2023, taking just under 600,000 calls, and I believe scheduling about 100,000 vaccine appointments. We also were on really that front line in real time, getting real-time information from the community that we could take back and help advocate for our callers so that they could have that equity and access to the resources that we had available. And that came in a lot of different forms of inequity, from language barriers to a big one that we saw was technology barriers. So go and print this proof of your vaccine appointment on your computer, or just take a screenshot on your cell phone. Assuming that everybody has all those things. So we were able to help advocate for our callers. But now that COVID funding has waned and we have had to cut our services dramatically. And the cold hard truth is that we've had one call center that recently laid off 50% of their staff due to funding. Others have had to freeze hiring and leave positions unfilled. 2 centers have reduced their hours of operation by 20%. Our current wait time on average statewide is 20 minutes. And our abandonment rate, those dropping the call because it's not being answered, is at about 33%. Our leadership staff is spending the majority of their time chasing funding, writing grant proposals, and meeting with our legislators and testifying for bills and budgets that can help fund our system. There are many jobs that require much less of an emotional expenditure of energy and pay the same, or oftentimes pay more than the specialists. So that's another issue that we continue to deal with. Washington State, we are fortunate in that we have the 2nd highest minimum wage in the country, but that has also created a financial hardship when our funding does not also increase at the same rate.
Stacey, thank you so much. That is such a reality check for folks who are on this call, who are not doing the frontline work that you all are doing. I think it's so important. And Tim, as we talk about distribution of funds, and as we heard from Stacey and Saskia about, not having enough to support these systems, can you talk to us a little bit about what you see and what you think makes sense in terms of investment? Tim, you're on mute.
Thank you. Just want to start off and kind of just recognize the questions that were submitted ahead of time of the webinar. And really it looked like this is probably the main issue for networks, is trying to get funding either to start a network and or sustain a network. So I know this is an important topic. When I looked at the data, I was surprised at how little funding there was from health systems. I made an assumption that investments in community referral networks would have been higher, especially since the movement towards holistic care, SDOH, and the COVID-19 pandemic would have changed those numbers. Referral networks like 2-in-1, we, like Stacey had said, we played a key role in connecting people to SDOH referrals while people were quarantining, and even more so now after the pandemic, we're seeing just a higher level of need for folks to get services. The largest source, which was the local government, it's kind of what we see in our own network. So there were no surprises there for me. Resource networks in Washington, they provide a key service for local and state governments, like related to homeless coordination, coordinated entry, rent assistance, utility assistance, basic food application assistance, transportation, employment, navigation, and disaster recovery, and others. So there's a lot of local government and county government and even state government that needs those types of services, but that's not our bread and butter. That's not per se information referral. So even though it does help fund the service, it also distracts from the referral and navigation work we're trying to do for other needs. The Backbone Support Organization, or lead investment organization, was somewhat interesting, but it was no surprise either, because often it's a necessity to invest agency reserves or revenue from other programs and services to supplement the care coordination and resource referral network activities within our network anyway. And also just, trying to fill those gaps in funding all the time, because it's never consistent. So my thoughts, about like the distribution of the investments and is it sufficient funding? The funding that we are able to generate is used primarily for direct staffing in about 3 areas, live referral and navigation assistance, our resource database curation and maintenance, and then outreach at a lesser extent. There is no permanent sustainable source of funding for 211 and this type of work. 211 has been, engaged in information referral coordination since the FCC approved the number for public use back in 2000. There's still no dedicated federal or state funding for 211. United Ways were the largest funders for 211s and CRNs before there was 211. But that's no longer the case since local giving to United Way has decreased, ever since the 2008 recession. So it takes multiple sources of funding to be able to make our network work, and I know a lot of others as well. This is usually revenue from contracts and grants to provide specialized services. Some of the ones I mentioned earlier. Washington won contracts with 7 independent nonprofit call centers. Stacy's one of hers being one of the call centers. We receive most of our funding from the state through ongoing legislative advocacy efforts, and we're there every year. But the funding only supports 15 to 20% of our entire 211 network cost to operate. 75% of the funds we actually generate from our local partners. So they are actually the ones going out, getting contracts and grants to provide specialized services, which in turn helps them to hire staff, then in turn are taking 211 calls. Because again, we get 1.5 million right now from the state of Washington, which we have to fight for every year. And believe me, that's not enough to fund staffing. So we depend on our partners to provide that. And this is the way it's been since our inception. We had an investment from the state early on, but then later on it just dwindled down. So we're trying to rebuild that again. So, like over the last decade, as healthcare has moved further towards holistic care, SDOH, and pay for performance, there's been a growth in CRNs as opportunities for financial support from healthcare sectors have increased, even though we didn't see that in the data. Washington State is a Medicaid waiver state that has 9 regional accountable communities of health. These regions have created or expanded existing CRNs through federal and state funding. The managed care organizations have also invested in SDOH strategies. They have included developing internal resource directories and care coordination platforms, or using vendors such as Unite Us and Find Help and others to provide a solution for their members. But this has also begun to open up funding opportunities for CRNs as MCOs and their vendors need help connecting and coordinating referrals with SDOH service providers within communities because they don't have that local connection. So that's been a value, one of the many values that we provide through our resource coordination efforts. And I think that's a key piece in trying to get some additional funding to support our activities. So, also looked at, where is funding going to be most sustainable going forward, or what is it now? So, nationally, human services, receive about 1/10 the amount of funding that the healthcare system receives, but only 80%. But 80% of person's health is related to SODH or SDOH. And it may take decades before we get that evened out at the federal level. There is this growing urgency, though, to provide SDOH referrals from the healthcare sector, but in many cases, there just aren't enough services available to refer them to. So we struggle with this. Stacy talked about it a little bit. It's demoralizing when you are trying to help somebody and there's no service on the other end to refer them to. To begin to address this inequity, many managed care organizations are beginning to pay for SDOH interventions, and services, including referrals. Governments and foundations are also investing more in health equity as a cause and could become a future source of this work as well. Unless there are major policy changes at the federal level, I think we will see healthcare become more of a sustainable funding source for this work.
Thank you, Tim. I really appreciate this. And as we are talking about this, wow, we could talk about this for hours. However, I'd like to open it up for some questions, and we'll bring Hannah back into the frame and allow the audience to share some thoughts or questions before we wrap up our session today. All right, thank you, Hannah, for joining us. So there's a question in the chat that says, how do you work with commercial social health information exchange software like Unite Us, Find Help, Pieces? Their model is selling to hospital systems, offering free service to CBOs. Are they competing with you or contributing, as Tim seems to say?
So I want to make sure I get that. So I'll just talk about our own community and what we're trying to do. So one of the things we see a struggle for some of these platforms, and of course with MCOs, is that they can't get that penetration in communities. They don't have those relationships. And so one of the things we're trying to do to incentivize CBOs to get more engaged in resource coordination, because again, they're understaffed as much as we are. And it's hard for them to adopt a whole new platform and do these types of referrals. It's an extra step they don't have funding for. So one of the things we're seeing, and it's been mentioned, is that there are there's abilities for for social care referral, for Medicaid reimbursement payment. There could be a share of revenue on those things. So we've had I've talked to some of the large, especially the large vendors that are doing some of this work in communities, and they're looking at partnering with those that have connections to communities to help engage and increase their capacity to be able to get more organizations to do these care referral networks. Hopefully that answered the question.
Well, we'll find out in the chat if it needs more clarity. But we're going to ask Dina's question. We are currently building a CBO partnership referral network, cited, but it appears as if the success of the network is out of our hands. Our approach is building a more intimate network that requires relationship building with CBOs. Do you have any tips? And that's for anybody on the call.
I can take that one because I know we are also working with path-cited funding, which is the infrastructure stream of funding related to CalAIM. I think that the approach is fantastic. Working and building relationships with CBOs is vital to making our community resource network systems work. And I think that, we are all in a space of it is a dynamic environment. So just continuing to strengthen the network. And I also wanted to speak a little bit to demonstrating impact of the network, because I think that often nonprofits and social service sectors like technology, both hardware and software, are underinvested, and historically we don't have resources to demonstrate the impact of services provided. So I think that through investment in community-led closed-loop referral networks, my personal hope and goal is that we can continue to add to the growing body of research for why providing social services impacts physical and mental health, and also demonstrating the impact of resource and referral networks.
Thank you, Saskia. I think that also kind of speaks to a question that was asked: to what degree are the impact metrics standardized? Are you experiencing any issues with interoperable data across settings support evaluation efforts?
I guess I could talk to our experience. We've done it's not statewide, but we've had like regional data sharing agreements and client sharing projects going on. There's one in Stacy's area what we do with Sheba volunteers. It's been pretty successful. But that one actually is not really funded though. Is kind of a way for us to we have really great software. Our system's very functional. We can do a lot of creative things. One of the things it's really good at too is doing API exchange of resource data, so we can communicate and work with other softwares. And I think again, when we look at funding too, those can be opportunities if you have a good software system and are able to connect and share and doing resource coordination with other organizations. And going back to the CBOs again, any way we can incentivize them to support, again, the offer of free software is not always it's kind of the first offer, but that's truly not always the best offer we can do. But I think, are there ways that we can, and we look at this, is can we collaborate. So like, there's other organizations doing information referral. Can we work with them? And we've done a couple of projects where, we partner with an organization who hires a care coordinator person in that community, and they actually become like our resource specialists for our 2-in-1 region in that area. And so there are folks on the ground, identifying resources and updating resources for us so we can do our job better and make sure there's healthy resource information in those communities. So those are some of the things that we've been working on.
And could I just add quickly that something that's really important, I think, to really kind of underscore is that these systems are powered by people. And I have way less concern about the technology. The technology is there. We can do all of these closed loop referrals right now with the software that we have. But I think that the technology should enhance the human experience, not take its place. And, we've had experience through the COVID information line with chatbots and AI, and I understand that that can be a wonderful help in certain situations. And contrary to what they're saying, I don't yet believe that the computers can emote and empathize as well as our humans can. So just making sure that we continue to focus back on that human connection. And I think that a lot of people that have come into this space are selling a database, are selling a list of resources, and they don't necessarily have that human connection component available.
Thank you, Stacy. That's so important. And as we are at the 1-minute warning I've received from our team, 10 seconds quickly, what are the takeaways from this project that you're going to lift up and think about? So 10 seconds each. Saskia.
I am just so grateful. I think this is, it's incredibly insightful to see the commonalities and differences of resource networks across the country. And I'm really going to take away that this work is incredibly important, and we need to continue to develop our community resource networks across the country.
Stacy.
I feel validated. I don't feel alone. I feel like we have this large network that is nationwide to draw upon. I've so enjoyed hearing about the experiences of the different partners that were a part of this project, and that this work is getting the attention of investors and of an organization like Health Leads, and lifting this work up in the manner that you have. As I said on one of our meetings the other day, I just want to take all of this and set it in front of our legislators and say, look what we found, which is what we've been telling them for years. So thank you so much. Thank you for validating us and for lifting this work up.
Thank you. And Tim?
For me, it's that opportunity to do storytelling, because again, I think we can get our messages across a little quicker when we can actually share what we're seeing in communities. I think a lot of, organizations that want to fund this work or want to engage more in social determinants of health referral work in these networks are just, they don't have that opportunity to be on the ground and learn from folks. And here we are, and having this opportunity to share that information, put it into a study that people can refer back to and say that, this is a reality. There is no sustainable funding for this type of work, but it is so important in what we're trying to do. And so I think it really helps us kind of plant a flag and say, hey, funders, others, please support this work.
Thank you, Tim. And Hannah, I know that you will allow me to keep us moving so that we're already a minute behind. So with that note, I just want to thank all of you so very much for your partnership, for your willingness to help us lift up this information and story. And, to everyone, thank you for joining us in this conversation. So you've already seen that we've launched the Zoom poll, so please take a moment to fill that out, and as well as the evaluation. And so today's slides will be on our website, and then you'll get an email with them. And we will be able to read the full report very soon. It is in the hands of our team, getting ready to polish it up and send it your way. So please be looking for that in email and on our website. Thank you so much. I am Artrice Morrison from House Leads, and I wish you all a great day. Goodbye.